7 o'clock. So everybody, thank you for coming to our evening with UVA Ortho. Dr. Winston Gwathmey from UVA Ortho Sports Medicine. This has been, again, I just mentioned that a bright spot for us is to be able to collaborate kind of with everybody in the evening like this. I know that for us as orthopedists, we're kind of, I know physical therapists, athletic trainers out there too are looking for some stuff to do. So there's no reason we can't still learn and share knowledge. And so it is a great pleasure for me to introduce my good friend and partner, Dr. David Diduch, who helps take care of UVA sports with us and is one of the gurus out there who's going to solve articular cartilage problems this evening. So after tonight, we can put that one behind us and have that solution set up for us. So Dr. Diduch, the floor is yours. Thank you for being here.
Thank you, Winston, and a special thank you to Winston for all of his organizational abilities and efforts to put this together and to link this this broader sports medicine community. So Winston, you've really worked hard at this as well as these people don't see it maybe, but a huge conference load for us as a department and kept our educational mission ongoing. So we really have a debt of gratitude to you. But thank you for this time. So as Winston said, I'm Dave Diduch. I'm at the University of Virginia, been there now 25 years. Cartilage treatment options continue to evolve. They've evolved a lot. We have much more available to us now, but it still can be confusing, and I hope to make some sense of it. And the other thing I hope as people are still signing on is that folks have kind of found a silver lining amidst all of this. I know I've really enjoyed spending more time with my wife at home. I've, cuddling on the couch, watching TV, something we never do. So it's been nice and getting outside a little bit more. And just to let everybody know that we are ramping back up. Actually, very quickly, we started operating again this week, and next week we have our full ORs available. So we'll start that backlog of surgical cases, try to get those done. And we're also ramping up clinic. Next week is kind of a transition, but the week after we'll be having clinic visits. We still have to space them a bit so that folks aren't jammed in the waiting rooms or in the hallways. So the volume's overall a little bit less, but certainly accessibility has returned and we're treating patients again. So amen. So just wanted to let you guys know, so you're key partners for us with our patients, both with post-op as well as non-op, and you will obviously be seeing a whole lot more referrals starting right now. And so we thank you for helping us treat these patients. So let's talk about articular treatment options. In 2020, here's our menu. These are the things we can do. We can lube it, make it, debride it, shrink it, pick it, wedge it, plug it, transplant it, implant it, replace it, leave it, or wait for it. So what is all this about? Lube it refers to viscosupplementation. I don't want to make the mistake the president did for the podium the other night and talk about drinking Lysol. Certainly don't put WD-40 in your knee, but this refers to the hyaluronic acid compounds, Synvisc, Monovisc, all of those with that type of name are injected into the joint, and they can help in many ways. They can last longer than a cortisone injection, which lasts typically about 6 weeks, give or take. But the problem is it's expensive. It's roughly $1,000. And if patients have to pay cash out of pocket, very few want to do that. The insurance cost is less than that. The negotiated rates probably around $600, but still a lot of money. And what does it do? It's basically a lubricant. And then secondarily, that decreases inflammation and decreases pain. It is very safe to cartilage. So we don't have a concern about too many of these causing cartilage wear. That is the case with too many steroid injections. And so we have a limit of the max of 3 in a year for a given joint that we will use for a steroid injection because too many can be harmful to the cartilage. It can, and the cells may not survive. But this is different. This is actually healthy for cartilage. It needs to have cartilage in the joint to work for its lubricating ability. Once arthritis gets to bone on bone, it's too late for this to really be effective. We're seeing this drop off tremendously because most major insurance companies have now decided not to cover it. And so the burden falls on the patient. And when it's $1,000 or more per injection, Very few are opting for that. And honestly, it's hard for me to tell a patient that it's worth that if they're going to pay that out of pocket compared to a steroid injection, which when I said effectiveness is 6 weeks, but still the pain relief can last a lot longer. And quite often with a joint that's hurting, and you know this as therapists, they'll flare up. It's not like the baseline has gotten worse and it stays worse. Joints will flare up, and then you can knock that flare down, and a steroid injection can be really helpful. A course of physical therapy can be really helpful. There are a variety of ways for us to work on it, but we're seeing this really fade fast in terms of use in our armamentarium. What about the oral supplements? If we're going to try to make new cartilage, well, that's probably a mistake to say that we're going to actually make new cartilage. There is no evidence with either the HA injections or with the glucosamine chondroitin sulfate compounds that we make more cartilage. But it does seem to help people. There is symptom relief, and it's nice to know that it does not cause any harm. These are very safe. In studies, about 75% improve. Understand with any study, you've got a placebo effect that's probably roughly 30%. So, but there is some improvement. The evidence is kind of mixed when they do really stringent science and randomized controlled studies, but it doesn't hurt and it may help. And you probably all have met patients who swear by it. I know patients that do. Maybe some of you have taken it and found that it's beneficial. It does take a little while for the effect to manifest. So to tell people to at least give it a few weeks. It is okay to double the dose at first. It's pretty safe to kind of get that loading effect and see the benefit. And then what I tell patients is to take it for probably about 3 months, stop it and give it a few weeks and see if they can tell a difference. Because it's not like taking a Tylenol where you see the effect in hours. And if they can tell a difference after they stop, then they may want to continue as opposed to just blindly continuing to spend money and take this. So I don't think it causes any harm. Many of you have dogs and have arthritic joints, find that this is extremely helpful. There's no placebo effect in dogs, so there's something to it. Now, these are not regulated. This is in the vitamin category, so it's not FDA regulated. So impurities can really be a problem, and brands matter. You can think you're buying something that's the latest, greatest at the nutrition store, but it can be full of impurities and filler. These are all reputable brands I have listed here. Basically, the big chains like CVS, Sam's, Walmart, etc., their brands are going to be reputable, and you're going to be pretty safe. But you don't want to necessarily go off to some off brands here. Let's now talk about some surgical options. So arthroscopy to simply debride cartilage damage, as you see here. This is a kneecap, this is a shaver. You see the rough versus the smooth, and we're just going to shave it and smooth it up. That can be very helpful for certain patients, typically younger patients that are having mechanical symptoms. So swelling that's provoked by activity, catching, locking, buckling, mechanical symptoms like there's sand in the gears. Those are the ones that are going to be most helped by just simply debriding it, and especially if they're having effusions. That's a big key. And we want that alignment to be good. If they're very malaligned, then that's just going to be progressively wearing out, and you're not going to accomplish much by just shaving more cartilage. And it can't be too advanced. So how does it work? Well, here's a whole bunch of studies, and you see reasonable follow-up in this column here on the left. And on the right, the percent that are good and excellent results. So just basic summary, you see these are okay. Roughly 60% to 75% good to excellent results, so some improvement, so it can help. The problem is now that whatever we shave and remove is gone forever. So there is zero capability of the articular cartilage to heal and fill in after we remove the damaged cartilage. Zero capability. It's a remarkable thing. This is a rabbit knee, and a scalpel, as narrow as a scalpel is, was used to make tiny clefts down to, but not into the bone. And then this is a year later, and those scalpel blade marks are still evident. As close as they're actually touching when you're done just making a slit with a scalpel. They're touching side to side, but you have zero healing ability of cartilage. These cells that live in these these little holes here are called lacunae. They're surrounded by the matrix, and they're pretty specialized cells, and they don't do a whole lot of additional dividing or making more matrix. They're pretty quiet once they're in that little pocket, and so there's not any ability for these cells to divide and cross over and heal adjacent defects whatsoever. So that's the important thing to understand about just shaving cartilage, is it's gone. So here's a good case. I actually got this one from Winston. So this young player had a direct impact to the anterior of their knee, sliding into base, and then had mechanical symptoms, effusions. They couldn't load the patella in the weight room, pain, catching, and the season's about to start. So this is a small, focal, full-thickness chondral lesion with a flap. When we see a flap analogous to an orange peel lifting up, that'll give people these mechanical symptoms. The white stuff here on the MRI is joint fluid. This is irritating the joint. It's making more fluid. This is a perfect candidate to do a debridement. We go in and we shave this away. That flap here is shaved and smoothed and contoured. Yeah, there's a defect left, but you got a lot of healthy cartilage around it to shoulder this lesion. And this does great. And this fellow's back to sports very quickly, basically once they just get over the soreness and swelling of the scope itself. So there are other ways to take care of these chondral flaps and damage and frayed cartilage. Understand that the frayed cartilage doesn't actually cause pain. There are no nerve endings and there are no blood vessels at all in cartilage. So what hurts are the pieces of cartilage that catch, back to the orange peel analogy. So the pieces catching hurt, but this frayed stuff doesn't have any pain at all. So that has to be something we think about with decisions for surgery. There is another way to take care of this that came around several years back, to use these special probes that heat up at the tip, and it kind of melts the surface and can visually smooth it out even better than our other tools do. The shavers that we use can't give us this kind of a smooth surface. The problem is the heat kills the cells. This is the same area. This is a special stain done to determine if cells are alive or dead. Red is dead, and all of these cells, after just passing it in the general area, are dead. So over time, you just barely wave it past there. Now this is the size of the tip of a ballpoint pen. So this is a ditzel, a tiny little patch, just waved past it. And then a year later, you got this scallop defect because you killed all the cells in this area. So the word is generally out. There's very few surgeons, but there are some that are still using these heat probes. And the companies come back to us every so often and say, oh, this one's better. We solved the issue. It's better for these reasons. No way. Stay clear of it. Heat kills. It's just not worth it. And thankfully, none of us around here really got on that ship, and we don't have a whole lot of patients with problems. But you can imagine if you're aggressive with smoothing surfaces out, the disasters that you could see. So let's talk about what Winston alluded to, which is really, can we make new cartilage? Can we regenerate cartilage? And this truly is the holy grail to make new cartilage. And this is a challenge, but we have made a lot of progress. So let's start with the basics, and that is microfracture. And I'm sure everybody's heard of this and treated patients who had a microfracture done. But what does it mean? So you have a defect in the cartilage, and we start by kind of scraping away the scar tissue to roughen the bone. And then we're going to actually stimulate some bleeding. We're going to take a sharp tipped pick, and we're going to poke holes in the surface and get down into the bone beneath it. And there, the cells that live in the bone marrow are going to come to the surface with the bleeding that you get and fill this in with basically a clot that has some of these cells in it. And that will help this area to regenerate and heal. I'm seeing here, is there a problem?
I mean, so if people want to use
got it. I think that's why I was trying to catch my attention. I got it, no problem. Okay, so this gradually matures over time, and it fills in with the repair tissue, but it's not normal cartilage. It is fibrocartilage. And this is the same stain. This type of stain is taken up by the part of cartilage that helps hold on to water. Cartilage is the most slippery substance known. It is an amazing thing. It is the perfect sponge. So the cartilage layer, when it's normal, is made up of the cells, but also in between the cells, it's a type of collagen, but importantly, another compound called glycosaminoglycans that have a negative charge. That holds on to water, which is the joint fluid, in the pores like a sponge in the nooks and crannies, but also because of the negative charge by hydrogen bonding. So when you put pressure on the surface, you're squeezing out just a tiny film of joint fluid that the cartilage is trying its best to hold on to. So it's not like you just flatten the whole surface out like you squeeze a sponge with your fist. It only flattens out a little tiny bit, and this tiny film comes out, and that, with another cartilage surface on the other side, is incredibly slippery. Fibrocartilage doesn't have those negatively charged glycosaminoglycans. Plus, it has a different collagen type, so it can't hold water very well. And if you press on the surface, it's much softer, and the water just gets squeezed out very quickly, like squeezing the sponge with your fist, and it's dry. And so it no longer has that shock absorbing capability. So that's why fibrocartilage is inferior to hyaline cartilage. And then the other problem is it just wears out. If it's going to not hold water as well, it's not going to be as slippery. There's going to be more friction, and the collagen type just doesn't hold up. And so this is a year later. Here's early on at about 6 weeks. This is a rabbit. This is at 1 year. You see that this is just breaking down and deteriorating. Probably many of you have seen patients and you followed their progress. And I've seen this too, where initially the first 6 to 12 weeks, they're feeling improvement because this is happening. The fibrocartilage is just filling that defect and smoothing it out, and the cavity isn't there, and the joint glides better. Unfortunately, year 1, year 2, it can break down. Now, it does have its place, and there can be good results. Here's again a series of studies with good follow-up, and the results are pretty good, but not great. The good to excellent results are, as high as 80%, but also sometimes lower. So it does have some benefit. Where does it have its benefit? Well, smaller lesions, 1 to 2 centimeters squared, if you think about length times width, that have stable borders are going to be the ones we're going to do, and also good alignment. If you're overloading that compartment, that's no good. We often have to do this as a first-line treatment because of insurance regulations. A lot of insurance companies say they won't approve the more expensive thing until the patient's tried and failed microfracture, which seems kind of silly with the evidence I just gave you and everything else, but that's the world we live in. And unfortunately, that's the case. So when we're really thinking also about where it can help best, it's when you have a well-shouldered defect. So here's a smaller defect, and you can see that the edges can help shield the base of this for that repair tissue to fill in and to mature. Whereas here, because it's a broader defect, you're going to have way too much pressure and shear on that surface. That's going to make it tough for that area, for any repair tissue to work with the fibrocartilage, or really other cartilage treatments that we may do. So sometimes when we have these problems, we got to just work on the mechanics. And if the alignment isn't good, we can correct that with an osteotomy. Osteotomy means to cut the bone. Osteo, bone, tomy is to cut. So we cut the bone and we change the alignment. And this has, very, very good results for specific problems. 85% good to excellent at 5 years. It does drop off with time, but this can be a good way to do two things. One would be buy time for a person who's not yet old enough and has an arthritic joint in just one part so you can unload it, or to maybe unload an area where you're really trying to get a home run with a cartilage treatment procedure. So we use it both ways. Even though patients are allowed to do anything they want once the osteotomy is healed, good studies have shown that they don't actually increase their sports participation, even though that may have been the driver to do the osteotomy instead of a joint replacement, because they want to do sports. When you really look back at what they did, they really don't increase their sports to any meaningful degree in most cases. So here's a good example. This person, mechanical alignment, looking at their weight-bearing axis from their hip to the floor, passes through the lateral side of their knee. It should go just to the medial side of the knee there. We can measure the angles, do the math. It's pretty straightforward, and we can then make a cut in the bone here, open it up like a wedge on one side, fix it with a plate and screws. There's the wedge. It's packed with bone graft that's now healed, and then you can straighten out that knee, and now the weight-bearing forces are distributed evenly across the joint. This is a very, very powerful tool to unload both repairs that we do and to slow down progression of arthritis. If I see a young person come in and they've already gotten arthritic changes in the knee on one side, this is the first thing I'm thinking about, and it will be a life changer for somebody. Yes, it's a big procedure. Yes, it takes a while to get better. You guys know this. You treat these people, but on the other side of it, it is well worth it if they start out malaligned. Very powerful tool, especially for the young patient who have a lot of years ahead of them. So let's think about ways we can specifically fill that defect. So you may have heard of the term Oats. Oats is actually one of the company's names for the tools that they use, but there are a few companies that make these tools. So it's probably better to understand this for what it really stands for, which is an osteochondral autograft transfer. Osteo, bone, chondral, cartilage. So it's a plug that has cartilage on the top and bone beneath it, and it's used to fill a defect. So that's the transfer part. The A stands for autograft because it's coming from the same patient from a different part of the joint, and this can fill in very nicely. This was a basketball player. This player was back to full play in 6 weeks with a single plug. That is at one end of the spectrum, but it highlights that the autograft plugs heal very fast. They're pretty much healed within just a few weeks, and it's just a matter of the insult to that joint with where we take the plug from in another part of the knee having time to recover in terms of their return to sports. And we've seen D1 athletes return to their sports within 6 to 12 weeks when you're talking about just 1 or even 2 plugs. So this is how the general idea. We take this cylinder that has a little tooth at the bottom, so it's hollow, and we're going to take it down through the cartilage into the bone, twist it. It's going to cut off the plug at the bottom, pull it out, and they'll transfer it to another part of the joint. Here's a case of the guy that tried to live with this bad meniscus tear, and this piece was just catching and locking mechanically, abrading the cartilage. This is the reason you don't want to just live with every meniscus tear. When it's giving you mechanical symptoms, this is what you get. All the way through, full thickness down to bone. That would never come back. Remember that about cartilage. So we're going to do an osteochondral autograft. I'm going to drill this down first through the defect where the bone was exposed. We drill it down deep enough that it's going to make the plug stable. And then we harvest from another part of the knee. This is where we're just checking our depth. And this is the plug going down inside of a plastic tube. And we're tamping it down with this little tamp at the other end, lightly tapping it with a mallet, and it goes deeper and deeper till it's all the way down inside and it's flush. And that's what you get. So the problem, though, is that you're going to have to take the plug from somewhere, and that comes with a cost. We can do it on other surfaces. This is a 14-year-old, very unusual, but he had osteochondritis dissecans of the kneecap. And you can see that he just really lost all of this cartilage plus the bone. So that cavity is deeper than just the cartilage alone, and filled it with 2 plugs, different sizes, and it filled it very nicely. And they're the x-rays. You notice the reamer has got a conical tip, so you get a little cavity behind it, but this is what you're really after, is the surface being flush. So we use this for really focal lesions. It can't be for broad wear, and moderate size, so 1 to 4 centimeters squared. So that's up to, at the most, 2 centimeters by 2 centimeters, right? But ideally for us, these plugs come at the most 1 centimeter wide. And for most of us, we'd like to be using this if I could get by with 1 or 2 plugs. Beyond that, this comes with a cost for wherever I take it from the other parts of the knee, and that's going to then be symptomatic. We take it from an area that's less weight bearing, but there is zero articular cartilage in the joint that sees no weight bearing. So there is no non-weight bearing cartilage to harvest. It's just areas that see less weight bearing. Thankfully, we now have another option, and these are allograft plugs from a cadaver. So they actually harvest them from a cadaver, and they're pre-sized. This is one in the same delivery tube, and it comes at like 10 or 12 millimeters long. and it's already ready size. So we just drill the socket and we can tamp it in. So now don't have to worry about morbidity from where we harvest it from. And we can use maybe then 2 or 3 plugs. When you start to get beyond that, then just the geometry of multiple round plugs doesn't make as much sense. And the other concern is you start to get too much of this cadaver bone beneath it, and you worry about how well that's going to heal when that's really thick, and you worry about it kind of sinking in. But this has now become our go-to in most cases, as opposed to the autograft plugs, to just go to an allograft cadaver-based plug for just these patients that need 2 plugs. It works great, and they have no donor morbidity issues, and these heal very readily. So when you get to a bigger lesion, then we're still talking about the potential to transfer cartilage with bone, but in a different shape. So this is an osteochondral allograft, and we're orthopedic surgeons, and especially us in our group at Virginia, are doing this more and more. It's really proven to be a very, very useful tool. So you get a whole knee or half a knee from a donor, and we size match it with x-rays, and it's got a limited shelf life, if you will. It cannot be frozen because the cells in the cartilage are actually alive. The cells that are in the cartilage layer, remember I said there's no blood supply, so it doesn't matter that that person has passed away. They're going to get the nutrition by diffusion of the fluid. So they put it in basically a media, and the cells can remain viable for a few weeks. The bone beneath it is dead. The cells in the bone are dead, but that can be the structural support. And if you track these transplants out for years, those same cells from the donor, 71% of the cells from the cadaver are in the patient and alive at 10 years. Because there's no blood supply, there's no immune rejection problem, and the body doesn't really replace those cells. This can be a great treatment option. So the issue, though, is if the piece of bone beneath it is too thick, then that's hard to heal. You have to let that's got to be basically turned over. The blood vessels will grow into the bone that's underneath it and replace it over time. And if it's a really thick piece of bone, sometimes that will be, as it's going under that remodeling process, it may crumble and collapse. But there seems to be very good results, roughly 85, 90, 95% with these larger, thin shell grafts, we call it. So the thinnest piece of bone we can get by with to support the cartilage. This is also called a bio-uni. You may hear that term. That's a commercial term, and we're doing this more and more. So here's a great case. This person, lateral side of the knee, osteochondritis dissecans, treated as a teenager, tried to fix it when it was an unstable fragment, tried to fix it with those absorbable screws, didn't work. You can see the bone is not very healthy beneath it. This is starting to crumble. The surface is collapsing. That's a real problem. And this was treated with an osteochondral allograft. This is at 3 months, and it's integrating so well, it's hard to even tell the borders. There it is there, and there it is here. It's basically the whole width of the lateral femoral condyle, and the contour we got was really nice. On the lateral, you can tell the thickness of the bone part of the graft. The graft is here on the end, but the contour, this makes it look a little funny, but the contour was just spot on. And this person did really well. We have to protect these. They have to be on crutches typically for at least 6 weeks, and we're really going to be protective for the first 3 months, and probably not back to sport for approaching a year in some cases, but a minimum 6 months. Now this will be a few examples of how we can push the limits with these, and we're really learning, but this is a patient with the problem in the patella, and it's just crumbling. I mean, this is a young person that's around 20 years of age, just crumbling, fragments of bone and cartilage, just a devastating problem, hurts them all the time. And you can see now in surgery, it's all crumbled. It was most of the patella, and we have tools to allow us to actually drill this out, create a socket that's going to match the plug we're going to put in there. We size match that patella, and we can press fit it in. And there it is from the side view. That was definitely a high five moment in the OR. And this will heal. We have to go even slower with these in the kneecap because of the shear forces. And we can use that to replace chondral defects in the patella, full thickness chondral defects. This is another challenge. This is on the other side. This is in the trochlea. So you have really some strange curvature problems. This is a concave surface. If you think about the plug analogy, if we're thinking about either using osteochondral autograft plugs, the Oats, or allograft plugs, if you're going into a concave surface, that's a real problem because all those plugs come from a convex surface. So if you take something that's a little domed and you try to fill a defect here, your surface congruity is going to be terrible. The other thing, but you can see we can actually do this with this large donor osteochondral allograft. The other thing that this highlights, this patient had failed a prior microfracture. So the green arrow on the left and the yellow on the right highlight a spur that formed inside of the actual defect, which is called an intralesion osteophyte. So for whatever reason, if you try to do a microfracture in the trochlea, it sometimes works, but often fails because we tend to see these things occur. Not sure why. It may have to do with all the shear that you get, but a microfracture in general is a less ideal choice in the trochlea, and because this can happen. Again, not always, but it is a concern. This person had to go on to this procedure. And this is kind of like a pebble in your shoe. It's very much more dense and firm than the cartilage that's around it, and so it can be very symptomatic. So let's get into some of the more exotic cell-based newer treatments, although those allografts, those bulk large bio-uni allografts are definitely new. But there's been some new ways to treat chondral defects with cells. The first was a procedure that came out of Sweden. It was called Autologous Chondrocyte Implantation. Carticell was another name for it. And that started by taking a small biopsy of cartilage and then growing the cells up in the lab and then putting them in a slurry underneath the patch. It's very expensive. It requires two procedures, one to go biopsy the cartilage, two to come back and put it in under the patch. This has been shown to though be very effective for larger lesions. Again, it has to be a focal defect. It can't just be the whole joint worn out, and you got to have good alignment. So there you can see a really large defect, two different patients, and then this patch is sewn in place. The first patches we used came from the periosteum, the lining on the surface of the bone, and it was quite tedious to sew these in place with these really fine sutures. Now we've gone to a patch that's sewn in place there, or even can be glued in place, and the results were pretty good. But we've really gone on now to the second generation of this, and that is instead of just putting a slurry under a patch, to put the slurry onto an absorbable patch and let the cells live there in the lab and kind of attach to that patch. So that's a tissue engineered matrix that has been seeded with the cells. The cells grow into that matrix, that patch, and so they're pretty happy there. The cells really like living in kind of that three-dimensional support, and then you can put the patch in. And there's a couple of brands. Novacart is not yet approved in the US, and it's undergoing a clinical trial currently. We're part of that group doing the clinical trial, so we can enroll patients for that, which is really nice. Macy is available now. This started in Europe, got approved there first, and is now coming over to the US. They're basically the same technique. And that's, again, back to the principle of taking a small biopsy, so it's not enough cartilage to really matter much to that joint in terms of morbidity or symptoms. You minced up into pieces and then get rid of the matrix around the cells. The cells then are in the lab, grown up, you multiply, so you have a lot more cells, and then you seed them onto this membrane, this absorbable membrane, and then you can put it into the joint. So here's one of the cases. You take these are tiny little holes that you use to get the biopsy. They're at the notch near the ACL, very minimal weight bearing there. This is the membrane that we get back, the patch, and this is me sewing it in place with really tiny suture. And this is kind of another patient, a larger defect. You can see once it's sewn in place, And there's the arthroscopic view. I've been very encouraged with how these patients do. So I haven't done any of the MACI, but I have done some of the clinical trial patients, and I've been very encouraged. This is an expensive procedure. This, as well as that other cell-based procedure, which is a two-step process, you're probably talking $40,000 by the time you're all done with both procedures. And most importantly, the cost for the company to grow these cells, seed the membrane, and send it back to you. So that's prohibitive in most cases. You've obviously got to get insurance approval for that. But it's an encouraging treatment and really is showing promise. And hopefully the price will come down over time. Another cell-based treatment that we have certainly used here, and other surgeons have around here, is this called de novo. So this is a little bit of a crossover. This is where we use minced actual pieces of cartilage from a very young cadaver donor. So a little unpleasant to think about it, but infants who catastrophically die, you can take the cartilage, and that cartilage has the ability to actually proliferate and grow. Unlike the adult cartilage we talked about, if you remember back to that rabbit slide with the slices with the scalpel, the cells will tend to migrate out of the little pieces of cartilage and proliferate and fill in and grow. So this is a defect on a kneecap. This is where we find it most useful. Some people who dislocate the kneecap knock a huge full thickness chunk out, and that can be a real problem. And that surface can be a challenge to work with. But thankfully, the kneecap cartilage is the thickest in the body. So that gives us a very deep well to put these small pieces in there. Then we put a special type of glue that sets in the body. This is fibrin glue, and the body turns it over. And we've had some really good results with this filling in. This doesn't work so well on a convex surface like the condyles of the knee, and you really can't practically get it in on top of the tibial surface. So where we find that it's most useful is on the kneecap. This is also expensive, not as expensive as the last one, but the price for this one little tiny vial of cartilage is like $3,000 or $4,000. So anything is expensive. The insurance companies find ways to put up barriers, and it's become actually harder with time to get this procedure approved, but we still do it in select cases. Here's an example. 18-year-old, played lacrosse here at one of the high schools, had a focal chondral defect from a traumatic event, big chondral flap. Here you can see inside the knee after we debride it, after we fill it with the pieces of cartilage and the glue, and did great. This is a couple years later, and he fell directly on the knee twice with a bike accident, oddly enough. Started to get new swelling and mechanical symptoms. The MRI showed that he had this lump down here, and he had actually gotten overgrowth, but had terrific, in terms of the repair area, had terrific integration and filling of that defect. So went in and just basically got rid of that overgrowth that probably got jostled when he fell on it off his bike, and with this starting to catch in the knee. And after that, he really had a very nicely restored surface and repair. So this is another option for us. So when is it just not appropriate to be doing these things? When I've used the word several times, but all of these things are only applicable for a focal defect, a divot in the surface with surrounding good cartilage and good alignment. When it's not focal and it's just worn out and it's on both sides, then none of these things work. Anything you put there, no matter how expensive or how you treat it post-op, is going to wear out again. Or if you have bad alignment, anything you put there is going to wear out again. So that's when it's better off just to leave it. And then, of course, you can all wait for it where there's more and more things coming along. I will say that the newer treatments with MACI and the NovaCart, that type of approach, I think that's here to stay. I've been doing this 25 years. When I first started practice, the Autologous Chondrocyte implantation, that thing from Sweden, was brand new, and it's really I think advanced quite a bit. I think we'll see those treatments stick, and I obviously think we'll see the osteochondral allograft stick. So what we have available is so far ahead of what we had when I started 25 years ago. We'll see with time about growth factors. That's a complicated thing to study because you just don't know whether that's going to have a negative effect. And it takes too long and too many patients to know. Otherwise, you'd think with all this recombinant growth factor technology we have, you'd just be, wouldn't that be a great way to rev it up? But it's a tricky thing to study and make sure you don't cause something that's a problem like a tumor, which has been shown in some studies, not necessarily with cartilage, but in other areas where we've tried to just use growth factors, you can have the effects you don't want. And the resorbable carriers are getting better and better. So to kind of sum it up, so I think of these problems in terms of size. If it's a small area, especially with mechanical symptoms, I'm going to debride it or think about a microfracture. One thing I didn't mention is that microfracture takes a long time for the rehab process. 6 weeks on crutches, and really return to sport is 5 to 6 months. And that's a long time for a little area if you can get by with just debridement and you're back in 3 or 4 weeks. There's no question about it. So we really kind of weigh the pros and cons of, is it worth it to do that microfracture and have that downtime? When the lesion gets bigger, we're thinking about a plug transfer. And if it's their own bone and plug, then it's going to heal very fast. They're off crutches in 2 weeks, and they are back to activities really when their knee can tolerate, so 3 months. If you use a cadaver plug, we may wait a little longer, but if it's just 2 plugs or 1 plug, that's not going anywhere. And that's pretty safe to come off crutches also very quick, and a similar timeline for return to activity, probably inside of 3 months. Once you start to get a bigger lesion, then you go into this large structural, big bio-uni osteochondral allografts or the cell-based techniques. Now you've got a much longer process. You're going to have to be much more cautious with the rehab, and you're talking 6 to 12 months to get back to full activities. And, good principles, you got to first say, before you get wrapped up in the technology and what's latest, greatest, well, how did that get there? If it just wore out, then it's probably alignment, and anything else we're going to put there is going to wear out too. So you got to correct the alignment. If it's a single traumatic event in a divot, that's where we're going to potentially have a home run with these treatments. And this is, certainly something we have to navigate all the time. So that wraps it up, and we have time for discussion. I'm going to put up this picture just because can't get enough of it.
Yeah, we're still the reigning champs.
We are, 2 years running.
Well, Dave, that was outstanding. That was really, really good. Pretty much covered the entire gamut. I think we got it cured. So a couple of questions from the audience. What is your preferred site to harvest plugs for Oats in the knee?
My preferred site will be on the lateral edge of the trochlea. So as far peripheral as I can get, just on the lateral side. If I'm going to need 2 plugs, I may take 1 plug there, and then I may go into the notch. So arthroscopically, we can go in, and just above the roof of the notch, we can take a plug. So I'm just trying to spread out the areas that are going to feel the pain, if you will. Too many harvest sites in a row is a real problem. But that's what we try to do. And the key is to get perpendicular. If you don't have a good angle and you take a plug that's crooked at the top, you can imagine what your joint surface looks like.
Another question. With the depth of the Oats and the conical tip in the example of the posterior patella graft, is there concern for compromise to the strength or integrity of the patella itself?
Good question. That's a small enough area that's still packed with bone, so no. But you can obviously go too deep, and there'll be a stress riser on the other side if you have a bunch of plugs.
Do you backfill the plugs, or do you just let them, what do you with the harvest site?
I let them fill in. I just let them fill in on their own. There's, over the years, there's been a couple of products that came to market as a backfill option that are basically polymers that resorb. Surgeons started to use them just to fill the defect as a primary fill, and that didn't work at all because they just started to collapse as the resorption began. So they had to pull it from the market. Other than just packing bone in there, I'm not sure there's something available right now. Are you, Winston?
No, I mean, I don't personally pack them myself. I don't know if there's a I mean, I've gone back on a prior oats harvest before, and they actually fill in pretty nicely.
They do.
In fact, I had one scenario where it actually had hypertrophy of the area there, and I think he was having some symptoms from that. So we shaved it down, the symptoms went away. So.
Yep, I've had the same. That happens on occasion, but you're effectively leaving a microfracture in that one small area, and it's just an area that can tolerate it better than the major weight-bearing zone.
Very good. So we have another question. What are your thoughts on other injectable biologics in this population? So I think beyond, hyaluronic acid.
Mm-hmm. That's a great question. I really didn't get into that, but I probably should have. So first, the marrow cells, stem cell injections. Let me first touch on stem cells. So stem cells are not covered by any insurance carrier. It's going to cost $5,000, easy. There is zero evidence that the cells that are injected go into a defect and fill it in with new cells. Zero evidence for that. That's very important for people to know. That is a common misconception. And there have been some really good studies done to try to demonstrate that. It does not happen, okay? There's zero evidence that if a joint's just kind of beat up and early arthritic, that the cells you inject kind of make that joint heal and make new cartilage. Zero evidence for that, okay? So you gotta be really careful about people who are trying to sell you stem cell injections. I'll say that. And thankfully in this community, we don't have a big problem with that. Some communities do. And it can be a huge problem, and people are vulnerable, and they can be desperate as patients and can be taken advantage of. So I hope you guys can help speak truth when people ask you these questions, but that's not what it can do. What can stem cells do? And there's a couple of sources. You can take it from, believe it or not, from your fat, like a liposuction, and that's a good source of stem cells. You can take it from your bone marrow. That's going to tend to make more bone than what you want. And then you can also take it from the umbilical cord. So that's another source. But none of them are going to make new cartilage, okay? But what it can do, probably through growth factors and things like that, is quiet a joint down, and it can be less inflamed. So it does have a role there for symptom relief. It can provide symptom relief. Understand this, if you just inject salt water, you get symptom relief, okay? So when people are trying to devise a new clinical trial and it's going to be double-blinded and randomized and all these other things, the FDA has decided that just saline is a positive control because patients get symptom relief, not to mention the placebo effect of spending $5,000 on what you think is going to magically make your knee better. So you can tell I'm not at all keen on stem cells. The science just isn't there. Now, the effect of just the growth factors and quieting a joint down that's inflamed, I think does work with PRP. So platelet-rich plasma, so you draw the blood off, you spin it down, you take that one layer and you can inject it in the knee. That definitely has a role to quiet a joint down that's inflamed, and you get about as much symptom relief as you do with a cortisone injection. Definitely has shown benefit with well-done studies. So I have no problem with a PRP injection in a joint. Problem is that it's expensive and not covered by insurance. So you're going to have to pay out of pocket probably at least $500. And I can't tell you that it's going to be any better than the relief you get with a cortisone injection. Nobody can. Nobody has shown that it's any better than what you get with a cortisone injection that is cheap and covered by insurance. What's the advantage? It's safe to the cartilage. So if you're worried about toxicity from what you're injecting to the cartilage, then that may be one reason to go to PRP if you have to do too many injections in a year to feel safe about a cortisone injection. Cortisone injection is very safe. I mean, in young people, we're more cautious, but a single cortisone injection for some knees that are really flared up can be a game changer to allow them to then progress with you guys with the therapy to really make the differences that are going to stick long term. The injections are temporizing things. So I still go back to what works, is tried and true, is inexpensive and is covered, and that's a steroid injection. But a PRP injection is perfectly fine, but it's going to cost you $500 out of pocket. That was a long answer, but I hope it addressed the question.
To follow up on your cortisone comments, I think that my value with cortisone, we have a lot of therapists and athletic trainers here on the call right now, is that sometimes people, they fail to progress with therapy because of the pain generated by their joint. And so I use it as a augment to their therapy. If I can quiet that knee down for 4, 5, 6 weeks, then maybe the progress you're making in quad strengthening or core, or whatever it might be for the hip, they can make that progress. And then suddenly when that, cortisone doesn't stick around for very long from a pharmacological standpoint, but the effects can be very long lasting by virtue of how patients rehab during the time when their knee has calmed down. So I think there's huge value there. And that's why when a patient asks me, what do you think about cortisone and I'm like, well, I think the value really honestly is, and if we can get you feeling even a little bit better and you can utilize your body's, improve the mechanics around your joints because of being able to strengthen by doing therapy, it can be super helpful. And so I think that's
Absolutely.
That's why I use it.
That's exactly my mindset.
So real quick to the audience, before I ask the next question, I'm going to launch a quick poll. We have a couple more of these coming up. I just want to make sure I have a good time for everybody. So I'm just going to launch a quick poll to see what time, if folks like to do this. We've done it at 8 o'clock, we've done it at 6 o'clock, we've done it at 7 o'clock. Just kind of want to get a sense of where people are with this, okay? Chances are it's like 25%, 25%, 25%, 25%, but we'll see if we can just at least I'm just trying to make this as accessible to everybody as possible. So Dr. Diduch, to all the therapists and athletic trainers out here who are rehabbing these injuries, how can you counsel them as far as rehab thoughts for a cartilage repair? It's like, let's just say an Oats or a microfracture or something like that. What are the concepts of rehab for that?
Yep, great question. All right, so a plug transfer, that plug is press fit and that's going nowhere. And even if that patient misbehaves and we lose them to follow up, honestly, I'm not worried, okay? So it's kind of just get their joint over the insult of surgery, get the swelling and the range back, swelling down, and that they're gonna be fine, get their strength back. And honestly, that's really as simple as it is. When you start to do a bigger graft with the bone, there we've got to be careful because if they're weight bearing too much, that doesn't have a chance to integrate. They're press fit in place. They're not fixed with additional screws or anything else. So there with a larger bio-uni with a big graft, that could potentially start to toggle. And if they're weight bearing and too much, then that toggling is going to prevent it from healing, and that could be a disaster. And that thing can completely fall apart and crumble. So we're strict with the crutches for the first 6 weeks. Think of it just like any other broken bone. It's got to have 6 weeks to heal and start. And then we're very cautiously, slowly with our protocol, advancing weight-bearing resistance exercises, slowly adding impact once we have definite bony integration on X-ray. Typically 3 months even for a light impact, but it's 6 months before you're really starting to load that knee with impact in an athletic way. So very careful with those. The cartilage regeneration procedures that are cell-based are the same, like the Macy and those types of things. So there it's going to be a slow process, and it's the same with microfracture. When we first put it in, be it that patch or be it the regeneration of the tissue that comes there from the microfracture, that's very soft and friable, and you really have to protect it. Motion is good for it. Remember that the cartilage, without the blood supply, gets its nutrition from the fluid diffusing in. That happens because it slides, because the joint moves, but you just can't have too much shear against the surface. So motion is healthy, but just without weight across it. So we try to minimize to 25% weight bearing, sometimes 50%, but definitely always 2 crutches, doing motion, 6 weeks of that until that starts to mature enough and it's integrated and attached and then slowly advancing. But the process for those is probably 6 months as well before it's mature enough to really start to push it into more aggressive strengthening.
Perfect. So 7 o'clock seemed to have won, but I think I was going to give one more quick poll to see if 7:30 would be preferable. One last question, Dr. Diduch. If I'm a therapist rehabbing a patient who's had a cartilage repair procedure, what should be some signs that I should be worried that the person's send it back to the doctor, I guess you could say, effusion, mechanical, like what would raise alarm to you or to me?
Diffusion. Effusion is probably the biggest clue to us that that joint's pissed off. And it's not happy because of the load, the activity, maybe things are deteriorating and mechanically irritating the joint. So if they're starting to get more swelling in the joint, that's the clue. So if you're seeing that, the first thing you tell them is, hey, you got to back off. Your joint's ticked off here. Whatever you're doing, understand it's more than the joint can handle. And then that'd be a red flag.
Perfect. Check it out. 50-50. I knew it was going to get that. All right.
7:15.
Exactly. We'll do it 7:17 and 22 seconds from going forward. So are there any other questions from the crowd? Feel free to unmute yourself or use the chat. I like to keep these things precisely under an hour so nobody feels like these drag on, because I think there's Zoom fatigue out there. I'm not seeing anything else. Dave, I just want to say thank you. Oh, wait, one more, a couple. In the future. Oh, there you go. Pretty open-ended question. What about the future?
I think I would have answered this question differently 10 years ago, 20 years ago. I would say that now we're really in a pretty good place. I think the Macy Novacart thing, I think that's here to stay and really very effective. I think it's pretty good. And I think when you get to a bigger defect with bone loss too, I think these osteochondral allografts, and what we'll see is probably a way to extend the shelf life, and maybe larger off-the-shelf plugs so that we can, in the moment put them in, ways to preserve them with the media and not freezing, because that would kill the cells, but the refrigeration. So that's what I think the future is.
Perfect. Well, Dr. Diduch, I just want to say thank you. I think that was just awesome overview of everything we could possibly talk about cartilage. So look forward to the next one. I think it's going to be Dr. Scheimer talking about back pain. I'm sure back pain happens in your clinic. And so we'll look for a time to do that, maybe not next week, but the following week, okay? So thank you, everybody. I'll send a link out to the recording of this, and we'll do it again. All right. Thanks again, Dr. Diduch.
All right. Thank you, Winston. Thanks, everybody.
Adios.
Bye.